I reviewed the case of a 72-year-old woman who had been slowly dying, and every single doctor she saw told her she was fine. Her heart was deteriorating. Her energy had collapsed. She was waking up at 3 in the morning in agony. And for 2 full years, the medical system looked at her and said, "This is just aging. Nothing to worry about." When I finally sat down with her complete medication list, I found the answer in under 5 minutes. It wasn't a mystery disease. It wasn't bad genetics. It wasn't aging. It was 5 pills she had been taking every single day, prescribed by good doctors, following standard guidelines that were quietly destroying her heart from the inside. And here is the part that should concern every single person watching this right now. At least one of these 5 medications is almost certainly in your home at this very moment. I'm Dr. Sarah Ellison, and I've spent over a decade as a practicing cardiologist focused on one specific problem: why so many adults over 60 do everything right and still end up with a heart that is failing them. What I've found time and again is that the answer is hiding in plain sight. It's in the prescriptions sitting on the kitchen counter. Today, I'm going to walk you through 5 specific medications that millions of people over 60 take every day and what they are silently doing to the heart that almost no one talks about. This is not about telling you to stop your medication. This is about giving you the information that a 7-minute appointment almost never has time to cover, so you can walk in and ask the right questions before it's too late. Stay with me through all 5, because the last 2 are the ones that took medicine an embarrassingly long time to recognize. And pill 5 is advice I gave my own patients for years, before the data showed me I was wrong. Before I name the first pill, I need you to understand something about the body you're living in after 60, because it changes everything. After 60, your kidneys filter more slowly. Your liver breaks down medications at a reduced rate. The average American over 65 takes 4 to 5 prescription drugs simultaneously. Some take 8 or more. Every single one of those drugs was tested and approved individually, never in combination, never inside an aging body already managing multiple conditions at once. So what happens when you stack 3, 4, 5 of these medications together inside a system that can no longer process them the way it used to? That question almost never gets answered in a standard appointment. And that silence is exactly where the damage hides. Now, I want to tell you about the patient I mentioned at the beginning. I'll call her Margaret, 72 years old, retired teacher, did everything right, walked daily, cooked her own food, kept a health journal, never missed a follow-up. And for 2 years, she was falling apart. Bone-deep exhaustion that no amount of sleep could touch. Leg cramps at 3 in the morning so severe they left her shaking. A mental fog that crept in so slowly she almost convinced herself it was just age. And heart palpitations, a fluttering irregularity that came and went without warning. 3 doctors, 2 years. Same answer every time. Margaret, you're 72. This is what aging feels like. When I reviewed her complete medication list, I saw 3 simultaneous problems within minutes. Not 1, 3, all working against her heart at the same time for 2 full years. We'll come back to Margaret, because what happened next is the entire reason I'm making this video. So let's start with pill number 1, statins. If you're over 65 in America, there is roughly a 1 in 3 chance you are taking a statin right now. Atorvastatin, rosuvastatin, simvastatin. The names change, the mechanism is the same. And I need to be clear, statins save lives. For patients with established heart disease, the evidence is solid. I've prescribed them countless times, and I stand behind that. That is not what this is about. This is about what statins do beyond lowering cholesterol, something buried in the fine print that almost never makes it into the appointment. Statins block something called the mevalonate pathway to reduce cholesterol production. But that same pathway also produces something called CoQ10, coenzyme Q10. And that distinction changes everything. CoQ10 is the fuel your heart cells run on. Think of it as engine oil. Your heart beats 100,000 times a day without stopping. Without adequate CoQ10, that engine runs rough, runs inefficiently, and over time, it breaks down. Research shows statins reduce CoQ10 blood levels by 30 to 50% in the organ that needs it most. In real patients, That depletion looks like fatigue that doesn't lift with rest, muscle weakness, mental fog, and in a significant number of patients, measurable decline in cardiac function. The very medication meant to protect the heart is quietly starving it of the fuel it needs to function. Margaret had been on a high-dose statin for 2 years. First problem found. Here's what makes this worse. CoQ10 testing is not standard practice. It's not in the clinical guidelines. There's no patent on CoQ10, no profit margin, no pharmaceutical incentive to push doctors to check it. The system has no reason to ask the question. The fix is simple. 100 to 200 milligrams of CoQ10 daily. The QSymbio trial showed measurable cardiac improvement in patients who supplemented it. And the only question I want you to write down before your next appointment is this: should I be supplementing CoQ10 alongside my statin? That's it. Write it down. Pill number 2, NSAIDs. This one surprises people because it doesn't look like a heart medication. For most people, it doesn't even feel like a real drug. It lives in the kitchen drawer next to the bandages. Ibuprofen, naproxen, diclofenac, the NSAIDs. Over the counter, cheap, and in virtually every home in America. The logic most people follow seems reasonable. Ibuprofen reduces inflammation. Inflammation is bad for the heart, so ibuprofen must be neutral at worst. That logic is exactly backwards. NSAIDs block an enzyme called COX-2. COX-2 produces prostacyclin, your blood vessel's natural defense system. It keeps vessel walls flexible. It prevents dangerous clotting. Block COX-2 and you strip that protection away continuously for as long as the medication is being taken. Simultaneously, regular NSAID use raises blood pressure by 3 to 5 millimeters of mercury on average. That sounds small, but in a body over 60, with arterial walls already. Losing elasticity, that chronic pressure increase builds over months and years in ways that accumulate silently until they don't. The FDA put a black box warning on NSAIDs in 2015, not just for stomach bleeding, specifically for heart attack and stroke. It's on the label right now. Most people taking ibuprofen every morning for joint pain have never read it. Margaret was taking ibuprofen daily for 2 years. For her knees. Her doctor knew. It was in the file. Nobody connected it to the palpitations or the blood pressure that had been climbing steadily upward. Second problem found. If you are taking NSAIDs regularly, ask about topical NSAID gels, same anti-inflammatory effect delivered locally, with 90% less systemic absorption. Curcumin with piperine has solid evidence for chronic inflammation. And Omega, 3 at 2 to 3 grams of EPA and DHA daily. The REDUCE-IT trial showed a 25% reduction in major cardiovascular events. That number deserves attention. Don't stop a prescribed anti-inflammatory without your doctor, but have the conversation. Because the conversation isn't happening on its own. Pill number 3, proton pump inhibitors. This is the one that took medicine the longest to connect to cardiac risk. And it's the one most likely to catch people completely off guard. Omeprazole, pantoprazole, lansoprazole. The PPIs, proton pump inhibitors. 15% of all American adults take them. Many for years, some for decades. Bought without a prescription, taken with morning coffee, never once considered a cardiac drug. Here's what the research has been quietly showing. Your stomach acid is a gatekeeper. You need it to absorb vitamin B12. Block that acid long-term, and you block B12 absorption almost completely. And here's why a cardiologist cares about B12. It's essential for breaking down an amino acid called homocysteine. When homocysteine isn't properly metabolized, it builds up, and elevated homocysteine directly damages arterial walls. It is an independent cardiovascular risk factor, comparable in some studies to high cholesterol, and it is almost never checked in standard cardiac workups. A 2013 study in the journal Gut found that long-term PPI users have B12 levels 30% lower than non-users. In people who are already losing B12 absorption naturally after 60, because the stomach produces less of the protein needed to absorb it. A drug-induced deficit stacked on top of an age-related one creates a compounding problem that builds for years before anyone thinks to look. B12 deficiency doesn't arrive with a dramatic announcement. It looks like fatigue, memory problems, a tingling in the hands and feet. In severe, prolonged cases from a heartburn pill taken for a decade with no monitoring, the neurological damage becomes permanent. But PPIs go further. They also deplete magnesium, and magnesium regulates the electrical signals that control the heartbeat. Deficiency is directly linked to arrhythmia. It is directly linked to leg cramps at 3 in the morning. Margaret's B12 came back critically low. Her magnesium was at the very bottom of the normal range, technically within range, so no alarm triggered and nobody acted on it. Third problem found: 3 medications, 2 years. Not one person had looked at all 3 together. If you're on a long-term PPI, ask for a B12 and magnesium level test. For B12 supplementation, methylcobalamin, 1,000 micrograms placed under the tongue, bypasses the absorption problem entirely. For magnesium, chelated magnesium glycinate at 400 milligrams daily is absorbed far more effectively than the magnesium oxide in most standard supplements. And one critical warning: do not stop a PPI abruptly. The rebound acid effect is real and severe. A gradual taper with your doctor is the only safe way through. So let's pause here, because what we've uncovered so far is already alarming. 3 medications. A statin stripping CoQ10 from the heart. NSAID removing vascular protection from the arteries. A PPI blocking the B12 and magnesium the heart needs to maintain its own rhythm. All 3 running simultaneously in the same patient for 2 full years. And every doctor Margaret saw was only looking at one piece. Nobody looked at the whole picture. 2 more medications to go. And I need you to stay with me because these next 2 are where it gets personal. Pill 4 involves a medication that prevents dangerous clots while quietly doing something to the arteries I have witnessed directly in my clinical work, something that almost never gets disclosed when the prescription is written. And pill 5. Pill 5 is the one I dread most, because it is advice I gave myself to women who trusted me completely before the evidence showed me I had been wrong. That realization didn't sit comfortably, but it matters too much not to say it out loud. Don't go anywhere. Pill number 4, Warfarin. Warfarin has been used clinically since the 1950s. It remains one of the most prescribed anticoagulants for patients over 65 for atrial fibrillation, deep vein thrombosis, mechanical heart valves. It works. It prevents dangerous clots. Untreated AFib carries roughly a 5% annual stroke risk that is serious, and Warfarin addresses it. I am not questioning its necessity for the right patients. But here is what almost never gets covered when Warfarin is prescribed. Warfarin works by blocking vitamin K. The problem is that vitamin K comes in 2 forms, K1 and K2, and Warfarin blocks both without distinction. K1 manages blood clotting, which is exactly why Warfarin works. But K2 has a completely different role. K2 activates a protein whose entire job is to prevent calcium from depositing in arterial walls and to direct it toward bones where it belongs. K2 is the body's calcium traffic controller. When K2 is blocked, that traffic control disappears and calcium begins to drift. It settles into arterial walls. And over time, those walls begin to harden and calcify, like pipes slowly filling with mineral deposits, becoming rigid, becoming brittle, losing the flexibility that a healthy cardiovascular system depends on. A 2019 study in the Journal of the American Heart Association found that long-term warfarin users showed significantly accelerated coronary artery calcification compared to matched patients on newer anticoagulants. The very patients whose doctors were working hardest to protect their cardiovascular health were experiencing an accelerated form of arterial damage simultaneously, silently. I have seen calcified coronary arteries. The calcification changes outcomes in ways that are difficult to overstate. It changes what is possible. If you are on warfarin, there are 2 questions worth bringing to your next appointment. First, given the newer anticoagulant options available today, medications like apixaban or rivaroxaban that don't carry the same K2 interference, is warfarin still the most appropriate choice for my situation? Second, has anyone measured my coronary artery calcium score? It is a simple, low-radiation CT scan that gives a precise, quantified picture of what is happening inside your arteries right now. One of the most underused cardiac risk tools in existence. One conversation, one scan. It can change the entire direction of your care. Pill number 5, calcium supplements. I have been a cardiologist for over a decade. I have made thousands of clinical decisions with the best information available to me at the time. And I am telling you directly, this is the recommendation I got wrong. If you're a woman over 60, there is a very good chance at least one doctor has told you to take calcium for your bones. 1,200 milligrams. Take it with food. Standard advice. Practically reflexive. I gave it myself without hesitation for years. In 2010, the British Medical Journal published a meta-analysis of 15 randomized controlled trials involving nearly 12,000 patients. The finding was unambiguous. Calcium supplementation without vitamin K2 and D3 was associated with a 30% increase in cardiovascular event risk. 30%. Imagine 100 women taking their calcium supplement faithfully every morning because their doctor recommended it, because I recommended it. According to this data, 30 of them may be meaningfully increasing their risk of a heart attack or stroke, while believing they are doing something healthy for their bodies. The mechanism is not complicated once you see it. Supplemental calcium enters the bloodstream as a concentrated surge, not the slow, gradual absorption from food, but a sudden flood that the body has to process all at once. Without K2 and D3 present to direct that calcium appropriately, the body cannot route it properly. And one of the places it ends up is arterial walls. The same calcification we just discussed with Warfarin, but this time driven by the supplement itself, not by a drug blocking the directional signal. You take a pill to protect your bones. Without the right cofactors, it hardens your arteries instead. Why haven't the guidelines been updated more forcefully? Because reversing advice given to tens of millions of patients over 20 years is institutionally complicated. There are liability questions. There are industries built around calcium supplement sales. It is easier to add a quiet footnote than to state plainly, we were wrong about this. I am stating it plainly. When I first read that BMJ data carefully, I thought about every woman I had handed that recommendation to. Every patient who was taking that supplement every morning trusting that it was protecting them. I couldn't have known what wasn't yet known. But I can make sure the next patient gets the complete information. That is why this conversation matters. If you are on calcium supplements, do not stop abruptly, especially with documented bone density loss. Bone health is real and matters. But bring this question to your doctor. Should I be taking K2 and D3 alongside my calcium? The evidence-based answer for most patients is yes. K2 in -7 Malawian kwachas form at 100 micrograms daily. D3 at a minimum of 2,000 IU. And wherever possible, dietary calcium first. Supplements to fill genuine gaps, not as the primary source. Now, before I tell you what happened with Margaret, I want to give you the one practical action I ask of every patient I see. Before your next appointment, write down every medication you take, every supplement, every dose. Then write 3 words at the very top of that list. What am I losing? Because every medication on this list involves a trade-off. Statins lower cholesterol and deplete CoQ10. NSAIDs reduce inflammation and strip vascular protection. PPIs suppress acid and block B12 and magnesium. Warfarin prevents clots and accelerates arterial calcification. Calcium supplements support bone density and, without cofactors, can harden arteries in the process. None of those trade-offs automatically mean the medication is wrong for you. They mean the conversation isn't finished yet. And you deserve a finished conversation. Now about Margaret. After reviewing her full medication list, I sat with her for nearly an hour. Not 7 minutes, an hour. Every drug, every dose, every interaction, every nutrient being quietly depleted. Then I called her GP and her internist. We built a plan together with Margaret at the center of every decision. CoQ10 added alongside her statin. Sublingual methylcobalamin started immediately for the critically low B12. Chelated magnesium added. Daily ibuprofen replaced with a topical diclofenac gel, same anti-inflammatory effect, 90% less systemic exposure. A gradual PPI taper began. K2 and D3 added alongside her calcium. No new surgery, no dramatic intervention, no breakthrough medication. We simply stopped taking away what her heart needed and gave back what had been depleted. 6 months later, Margaret called me. "Dr. Ellison," she said, "I feel like myself again. For the first time in 2 years. The exhaustion was gone. The cramps stopped within the first month. Her cardiac follow-up showed measurable improvement in heart function. Her GP called me genuinely puzzled. The trajectory didn't match what was expected for someone her age. Nothing had changed except that someone, for the first time, had looked at the whole picture. That is what stays with me. Not the complexity of what went wrong, but how simple it was to help, once someone asked the right question. The medications on this list are not the enemy. The doctors who prescribe them are not negligent. The problem is a system built to treat individual problems in individual appointments, with no mechanism to step back and ask what the combination is building toward over 2 years, or 5, or 10. You cannot fix the system today, but you can walk in with a list and 3 words at the top. And more often than you'd expect, that is enough to change everything. If this reached you today, share it with someone you love who is managing multiple medications and being told that their exhaustion is simply what getting older feels like. It may not be. Everything discussed here is grounded in published clinical research. Your situation is unique. Bring these questions to your doctor. This is Dr. Sarah Ellison, and I'll see you in the next video.